Good evening, and thank you all for joining us for this webinar, which is part of a series of presentations that will be delivered on alcohol and other drug use, funded by the Sydney North Primary Health Network. I would like to begin by acknowledging the traditional custodians of the land and paying my respects to elders both past and present, and extending that respect to other Aboriginal and Torres Strait Islanders who are present here today. My name is Christina Morell. I'm a Senior Research Fellow and Program Lead of Treatment and Translation among Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. I had the very great pleasure of co-facilitating this webinar tonight, along with Associate Professor Catherine Mills, which will be presented by Dr. Robert Fullerton. Dr. Fullerton is a Mental Health Clinical Lead for the Sydney North Health Network, former Clinical Services Coordinator for Odyssey House, New South Wales Community Services, and psychologist in private practice. He holds a dual PhD in Clinical and Industrial Organisational Psychology from the California School of Professional Psychology and has 10 years of experience applying motivational interviewing in government-funded managed care, university counselling, and private practice treatment settings. Robbie is dedicated to building collaborative therapeutic partnerships with clients based on respect for their autonomy, compassion for their ambivalence around change, and belief in the personal strengths that they can leverage in the service of changing patterns of behaviour that can compromise their well-being, and we're incredibly lucky to have him with us tonight. So before we begin, I would just like to draw your attention to the Q&A and chat buttons on your screen. So please feel free to click on those and type in any questions or comments that you might have at any time during the presentation. Robbie will also be asking a few questions throughout our live presentation. So to take part in these, please have your chat box open and ready to the side, and you can select to all panelists and attendees from the drop-down menu at the bottom of the chat box. We'll also have time at the end of Robbie's presentation to go through any questions and comments that you'll be sending through. If you experience any technical issues during the webinar today, you can call the technical support line with the details on the screen there, or visit the Zoom support webpage and chat with an online staff member. I'll also put this information in the chat box so you can find it if you need to during the presentation. We're recording the webinar, so if you'd like to view it again or download the slides as handouts, you can access them at the website on your screen. Lastly, please remember to complete the CPD assessment at the end of the webinar if you'd like to. And now I'd like to hand over to Robbie.
Great, thank you, Christina, and thank you very much for inviting me to do this presentation. So I'll be talking about applying motivational interviewing skills in general practice. Some of the objectives for this presentation will be to help you understand theories around motivation and change, understand what motivational interviewing is and when it is useful, and then how to apply it, so learning core motivational skills. And that's all to help you gain the ability to apply motivational skills in your practice when you're trying to coach clients into making changes in their life. So first of all, motivation. So motivation is a very strong predictor of change. A lot of times you notice that the best motivation is intrinsic. You can't really force anyone to make changes. They have to want to make them themselves. And that can be very frustrating when you think you know what's best for them and you don't see them doing much of a change on their own volition. But if you do get them motivated, it can increase their participation in treatment and it can yield very positive treatment outcomes. The desire to change is continuous, it's not dichotomous. So it's not like you're either really motivated to change or you're not. It can really fluctuate, and it's important to stay attuned to where the client is with their desire to change and how motivated they are. Ultimately, the practitioner and patient both contribute to the patient's motivation to change through the therapeutic partnership. So there's a little quote from Stephen Covey, who some of you may know wrote 7 Habits of Highly Effective People, that says, motivation is a fire from within. If someone else tries to light that fire under you, chances are it will burn very briefly. So that quote just illustrates that it's not necessarily us trying to stoke the fire under them. It's to try to figure out ways that you can ignite that fire within the client to make them want to make the change. So before I go into what motivational interviewing is, why are we talking about it? Why is it important? So research has shown that numerous controlled studies display efficacy for these various issues that you may see in your office. So substance misuse, smoking cessation, eating disorders, any domestic violence situations that people may need motivation to get out of, diabetes management, any changes in diet or regulating BMI, HIV, AIDS risk behaviors, or even adherence to medication, even things like oral health maintenance. A lot of these studies showed that it was really effective using motivational interviewing techniques. There was also a meta-analysis published in the British Journal of General Practice, and I've included the reference at the end of this presentation in case you want to look up the specific reference, that found that motivational interviewing was significantly better than other approaches in 3 out of 4 studies and outperformed traditional advice giving 80% of the time. Even in brief encounters of about 15 minutes or less, there were lasting effects using motivational interviewing in 60% of the studies that they included in the meta-analysis. So it's been shown to be highly effective, and there's a strong evidence base behind it. So what do we need to bring when we're practicing motivational interviewing? It really means that the practitioner has to be empathic, have a warm disposition, and be very genuine with the client. And the creators of motivational interviewing define empathy. As you can tell, empathy can be defined in a lot of ways. But in terms of motivational interviewing, we're talking about the skillful reflective listening that clarifies and amplifies a patient's experience and meaning without imposing our own material onto the patient. So I know this kind of goes against the grain with a lot of the things that we've been taught to do or that we want to do, just by telling people you need to make this change and here are all the reasons why. And I think a lot of us have had that experience trying to get people to change, really genuinely having their best interests at heart, but not seeing them quite make the difference because we're really imposing our own agenda onto them, rather than kind of exploring and walking with them in what the struggle is and figuring out how to get over that hump, how to get through that struggle so it's clear what steps they need to take in order to change and why they're motivated to go down that path. One of the things that really prevents people from changing is the natural ambivalence that comes with needing to make a change. There's a reason that we don't easily change our habits. We're highly motivated to not change and stay the same, yet there may be things that motivate us to change. Now, if a patient's in front of us and they're engaging in some behaviors that are dangerous, or you see that they have risky substance use, and that has really negative consequences toward them, you can point out all the negative things and all the things that maybe even they themselves know are reasons they need to change. But there's a whole host of things counterbalancing that, where maybe it's a source of comfort for them. Maybe it's all they've ever known. And those are things motivating them not to change. So that's kind of what we're fighting against. And it's really part of motivational interviewing to acknowledge that ambivalence as being natural and explore that ambivalence with the client, rather than just maybe weighing down that side that says you need to change, because it's let's look at the whole picture and try to understand this together and then figure out what you're going to do with that. In order to understand how to move people from not wanting to change to wanting to change, we should understand that there's several stages, if you will. It's not a perfect stage model because it's not thought to be completely linear, but this stage model includes different aspects of change that the client may be experiencing. One is pre-contemplation. So that's not having any intention to change. They may even be in complete denial that they have a problem. They might not want to acknowledge it. Contemplation, which means the patient's aware of the problem, but there's no commitment to action. So that's where they kind of think, oh, I could change, but it's easier just to stay the same. But I'm thinking about it. In preparation, they're intent on making a change, but they haven't quite taken action yet, but they're on the precipice of. In action, they've actually committed to taking action to change and have taken a couple steps or are taking steps to do so. In maintenance, it means they've taken steps to change. They've noticed some results and they see that they want to continue doing that. And your job at that point is really to support them in maintaining that. And then don't like the word relapse, but it happens to occur in this slide. Lapse or recurrence is actually a natural part of this cycle. And we should highlight that because people feel really disappointed in themselves, and shame can be really detrimental to the process of change. But if you normalize the fact that at some point, if they reach a lapse, that it may be part of their journey. And we have to acknowledge that and learn from that experience. Kind of acknowledge how far they've come to get to that point and try to shore up their resources to continue on the path of change. I'm going to go into these a little bit more detail with some examples. So pre-contemplation, as we said, is not considering a change. There's little awareness or concern of the negative consequences. An example of this you might hear is, my blood pressure readings have been a bit high, but I feel fine, so I don't think it's a problem. So there's not really any motivation to change if you don't see that it could be a problem. Contemplation is acknowledging that maybe you could use a change. This is highly characterized by ambivalence. You seesaw between reasons to change and reasons to stay the same, just in that last slide as we saw. I can see that it would be better for my health if I quit smoking, but it's my only break in the day when I can get some quiet alone time. So there are valid reasons why they would want to change, but there's also a motivation to stay the same because it serves a purpose. It's meeting a need of theirs. So that's hard for them to give up. In preparation, that window of opportunity is open, and you see that the balance has tipped from they really do want to make that change. And really it's about what kind of action steps can I take? What resources can I get around me to walk down that path? So I really want to lower my cholesterol. I just don't know how to go about it. It's a great opportunity. They're in preparation from a motivation perspective. And in the stages of change, it's really about giving them enough information and resources to take action. That brings me to action. They engage in particular behaviors that are designed to bring about that change. So maybe you've offered suggestions and they've actually pursued it and they've acted upon it. It may happen with or without any assistance. And there's determination to produce a change in the area. So they may say, after our last visit, I actually did book in to see the psychologist for my anxiety, like we talked about. In maintenance, they're just trying to sustain the change and the action that they're taking. And part of maintenance is also preventing relapse. So just affirming the efforts that they've taken, making sure that they stay on that path. A client in maintenance may say, the last few months on these medications have helped, but I'm wondering if I really need to keep taking them. So they've definitely made changes. They're taking action. There still could be some of that ambivalence, and you need to be aware of it so you can help them prevent a lapse. If a lapse happens, it's really important to normalize it. So it is a normal and expected part of the process. This does fall within the harm reduction or minimization approach to substance use. It's not necessarily about making sure that they stay abstinent completely for long periods of time. That would be great, but having a lapse can be a learning experience. And if we handle it with care and we encourage them despite the lapse, they may be more liable to stay along the change. If we shame them, if we discourage them or judge them, demoralize them, they may just feel like it's not worth putting all the effort into continuing that change. So really it's about help restarting them on that journey of changing and avoid getting stuck in this stage. So an example would be, I slipped up over the holidays and had a few drinks at a work Christmas party. In a little bit of an effort to apply this and see if you guys get the concepts, I'm going to do a bit of an exercise. So I have a few prompts, different quotes that you may hear from a patient. And then on the right-hand side, I have the stages of change. So I just want you to think about the quote when I read it out, and maybe in the chat, just type in what you think the stages of change will be. So I think I will book in to see that psychologist you recommended. Where might that person be in the stages of change? Great. I'm seeing a lot of people put some preparation down. So yes, definitely. Oh, I just lost light. 1 second. I'll continue on. So in preparation, you are thinking about what kind of changes you need to make and what steps you need to take. So they have decided to book into that psychologist, and they haven't acted yet, but they're planning to. Over the summer, I started going to Zumba classes on Wednesday nights, and I'm really liking it. What stage of change would that be? Yep. Seeing a lot of action, and that's a correct one as well. So they've taken some action. A little bit to distinguish action to maintenance is that they've taken some action and they've sustained it. So the people who have said action are correct because they've actually done something and they're continuing to work toward it. If they've done it for a sustained amount of time, they may be in maintenance, and the focus is to not only encourage the action, but be aware of the potential for relapse and support them through that. My weight isn't a problem, but you notice that their BMI is 31 with a waist of 100 centimeters. So where are we in the stages of change? Yep, a lot of pre-contemplative. So that's the correct answer. Yeah, there's no acknowledgement that there's a problem here, so why should I even make a change? I've started using nicotine patches to help me quit smoking. Where are we there? What stage of change? Yeah, there we go. There's a lot of action. So yes, they've just started to make the change and they've taken action toward it. I slipped up and have gone back to drinking since the Easter holidays. Yep. That one's very close to the example I gave. So a lot of you got that one correct with lapse. I know my sugar levels will be better if I stick to the diet, but I don't think I can give up sweets. Yep. And even if you just did that by process of elimination, it is contemplative. So it seems like you all have a pretty good grasp of those stages, which is really important because as a practitioner, whether you're a GP or allied health professional and you're coaching these people through changes, you want to know where you're meeting them, because the whole purpose of motivational interviewing is to walk with the client, and you need to be highly attuned to the client's needs. And the client's needs will differ depending on what stage of change they're in the process. So you may notice that you use different approaches depending on which stage of change. Pre-contemplative can be quite difficult, as a lot of you have experienced, and we will talk about how you may move someone from pre-contemplative, I don't have a problem, to maybe I should think about making some changes. So what is motivational interviewing? Traditional approaches to healthcare focus on convincing the patient to make changes, while motivational interviewing uses more of a guiding style to help patients think about the importance of changing their behavior. So not necessarily telling them what to do, but maybe having them reflect on why it might be important to them to make a change. So essentially, it's a style of communication that involves the strategic use of statements and questions to help clients find their own reasons for change. Because again, like we said in the beginning, it's got to come from within them. It's a person-centered, evidence-based treatment that elicits behavior change by helping patients explore ambivalence. So we said ambivalence is natural, and it's an inherent part of the change process. So we really want to meet clients in that space of ambivalence and help them through what they're going to do with that. It's an empathic, supportive, yet slightly directive counseling style that provides the conditions for which change can occur. It really hinges on being collaborative and honoring the patient's autonomy. So you kind of have to acknowledge that they're going to make their own decisions in their life, and the change and motivation will come from them. The ultimate aim is to support patients in exploring their own reasons for change and strengthen their intrinsic motivation to change, so change arises from within them. It can be used by itself, Or a lot of people complement CBT or DBT models of therapy with motivational interviewing to get clients to act. So what's the basis? Ambivalence about change is natural. That's a huge tenet, as we've touched upon. Ambivalence can be resolved by exploring the patient's intrinsic motivations and values. The alliance between the patient and the practitioner is a collaborative partnership to which each brings important expertise. Now, the patient is going to know themselves and the reasons why they want to change or not want to change, or what keeps the behavior in place better than anyone. So we really need their expertise. But, you know, we as practitioners have expertise ourselves that can guide them. And that's the purpose of motivational interviewing. The MI spirit. So motivational interviewing, because it's not necessarily always conceptualized as an intervention or a manualized type of treatment itself, it's kind of more about embodying the motivational interviewing spirit when you're walking with that client. So it involves being collaborative rather than being confrontational. So the attitude is really, we're going to work on this together. We're going to walk this journey together. You want to evoke things from the patient. And again, that's in honor of the fact that they know themselves best and they know what's ingraining this behavior. So I'm going to create a space for you to share about yourself and your story with me. You want to evoke a lot from them. You respect their autonomy versus highlighting that there's an authority relationship in the mix. So there's that sentiment of, I value you and respect your decisions. It's not about judging them. It's about evoking things from them and then opening up a conversation. And then there's, of course, compassion. I want to understand and respect you and your experience. The more you do, the better you'll be able to help them. So there are 5 principles, and they kind of equate to things that we do in motivational interviewing. So different approaches that we take. So we express empathy, develop discrepancy, and really it's just about pointing out that there is discrepancy causing this ambivalence. You avoid argument if at all possible, and there's ways that you can kind of strategically do that. And with argument, usually it arises from resistance. So instead of arguing against when people become resistant, we try to roll with resistance. And I have a lot of suggestions for how you might do that. And then you support their self-efficacy, because if they believe that they can make the steps that you're proposing for them to make, or that they've themselves created for themselves, you can help them believe that they can do that. So what do we mean by express empathy? So it's a skill for understanding another's meaning through the use of reflective listening. Requires sharp attention to each new client statement and the continual generation of hypotheses as to the underlying meaning. So really it involves listening and reflecting rather than telling the client. So it does mean that you need to open space for the client to share more about what the struggle of making that change is. Communicating respect for and acceptance of patients and their feelings. Encouraging a non-judgmental, collaborative relationship, and be a supportive and knowledgeable consultant. When we talk about developing discrepancy, we really just mean pointing out that there may be different things motivating them. So again, I want you to picture that there's reasons I want to change and reasons I'm not changing. This is what developing discrepancy is all about. So some of the examples of statements you could make to develop discrepancy include the following. So on the one hand, you haven't noticed any consequences of your drinking, and yet on the other, we see your blood pressure has been quite high, which could lead to more serious health issues. So especially in the early stages of a drinking issue, maybe they haven't had such bad behavioral issues, they've gotten in trouble with the law, or it's not impacting their relationships as much as maybe further down the line it would. But if you're already noticing trouble with, when their bloods are coming back, it could be something, it could open up a discussion about, I know you're feeling this one way about your drinking, but there's also this objective proof that we have. And how does that sit with you? Not necessarily telling them how they should feel about it, because I think we can have a tendency to do that. But pointing out the two things that you're noticing and putting it back at the client's table. The other one, I understand that you've had bad experiences on the pill, and I'm also aware that falling pregnant at this time would pose a big problem for you. How do you make sense of this? So again, you're not telling them how to feel, or you're not necessarily judging them. You're just saying, this has been your experience. This is also part of your life at the moment. What are you going to do? Another statement is, on the one hand, you're coughing and are out of breath. And on the other, you're saying cigarettes are not causing you any problems. What do you think is causing your breathing difficulties? So obviously that's a bit of a loaded question, but it's a genuine question. If that's not necessarily the issue, what could be the issue? But you're just pointing things that may contradict themselves, and leaving it up to the client to try to explore. And as they explore, maybe they come to their own conclusion that this may be because of my smoking, or it may be because of my drinking, and I don't want those consequences. Avoiding argument. So it may be tempting to argue against a client, especially if the client is defiant or provocative, but trying to convince the client that a problem exists or that the change is needed could precipitate even more resistance. And this is that kind of digging their heels in response that you might get. Again, if the motivation isn't coming from within, it's likely their defenses are going to come up because it's something they may be defensive or sensitive around anyway, and you're just going to get more and more pushback. So that's why we want to kind of be aligned with the client and kind of walk with them at your side through the conversation, rather than confronting them and being combative about it. So you don't want to get into an argument because it can turn into a power struggle. And again, you want to work with clients, not necessarily drag them to make a change. So again, resistance is really difficult. I'm going to give you some tools to roll with that resistance. Different types you may encounter are arguing, interrupting, denying, or ignoring. And I'm sure we've all heard responses like that. So some examples of rolling with resistance involved using reflection statements. Patient may say, I don't have time to exercise. Probably pretty common. You might come back with, your life is too busy at the moment to make time to exercise. You're not asking a question. You're just making a statement on what you've heard, and they can elaborate. And if they are contemplative or feeling two ways about that statement, they could say, well, I'm not too busy, or they may be thinking a little bit more about it, but you're just giving them the opportunity to elaborate. Another example would be, I really want to start taking my medication again. And the reflection would be, taking your medication is very important to you. So that's not necessarily with resistance, but it's just another example of a reflection that you could use. Amplified reflections kind of do the same thing, but they highlight something in the statement that they've just given you, and almost exaggerate it to the point where they have to argue against what they just said, if that makes sense. So a patient may say, I don't know why my wife is so worried. I don't drink any more than any of my friends. So you might come back with, so there's no need for your wife to be concerned about you. Now, there are probably a lot of reasons that the wife is concerned. The fact that it's even been brought up by the client, shows that there are reasons. So you're simply putting it back on the client to explore, no, there are reasons why she's concerned, and I'm gonna, the reaction is to explain that. You don't have to bluntly ask or to say, I know your wife is worried. Why is she worried? Just say, so there's no need for your wife to be concerned. Double-sided reflections do a really good job of highlighting the ambivalence, and maybe even highlighting some discrepancy. So a patient may say, I know how bad it is to keep smoking with my COPD, but I don't know how else to do. I don't know what else to do when I get stressed out. So you may say, so you can see how smoking can make matters worse for you, yet it has also been a source of comfort, and it's difficult to imagine how to manage your stress without it. So you just acknowledge the situation that they're in and really align yourself with that ambivalent feeling. Another one would be agreeing with a twist. So the patient may say, I can't picture myself not drinking. It's part of who I am. It's how I escape, and it helps me get through the day. Reflection or an agreement with a twist may be, you can't live your life without drinking. It's such a part of who you are. You will keep drinking no matter what the cost. Now, I know that sounds a little bit extreme, but the whole point is to align with them, maybe highlight or exaggerate what they're saying a bit. So maybe it gets them to tip the scales and argue against that point, because they're thinking, no, it can't be just who I am. I can get over that. You may want to shift focus if people are being resistant. So patient says, what do you know about depression? I feel like a failure all the time. You're a doctor. Everything turned out great for you. You might not want to focus on how you fit into the story. You might just want to highlight what the patient is feeling and what they're going through. So that could entail a statement like, it's hard to imagine how I could possibly understand how much pain you're in and what you're struggling with. So you're really just aligning with the emotion and reflecting that back, not necessarily getting in that power struggle. You can also reframe. So I've tried to keep my diet so many times, but I always slip up. You might just highlight the positive. So you're very persistent, even in the face of discouragement. This change must be really important to you. And that might encourage them a little bit as well. Using metaphor can help. So paint a picture for the client. Patient may say, I can't take too much more of this anxiety. So they're kind of at this desperate stage. You want to just highlight, you want to be in a better space. The other thing you could do is highlight the feeling. This is a reflection in the deeper form. If I don't stop drinking, I won't be able to qualify for a transplant, and I could die from this. It's a very serious thing. So just highlight what they're feeling. Just reflect back. You're scared. Your drinking could be a matter of life and death for you at this point. It doesn't necessarily solve the problem, but it allows them space to explore the issue in greater detail. And the more they talk about why they should be changing, the more motivated they might be. In supporting self-efficacy, you really have to have a belief in your patient. I know it can be sometimes hard when people are not changing on a consistent basis, and you wish you could shake them out of that, but you need to meet them where they are and just believe that at some point they'll get there. Optimistic empowerment is engendered in the patient to encourage change. You may foster hope and enhance your patient's belief in his or her ability to change. And you want to identify your patient's strengths and bring them to the forefront whenever possible. That brings me to some of the specific skills that are involved in motivational interviewing. And we'll go through these in detail with some examples as well, just because I think it's really important to see how these unfold in the consultation room. So it involves asking open-ended questions, not necessarily closed-off questions, because open-ended questions give the client the opportunity to explore how they're feeling and what their ambivalence is. It facilitates a dialogue and encourages them to do most of the talking rather than you kind of telling them what they should feel or think about the information that you may be delivering in the consultation room. Affirming. This supports that aspect of self-efficacy. And you want to do this whenever you see that they're thinking positively about change, or if you see them move on those stages of change, or you see them actually take action. You want to acknowledge that, because that'll support their motivation and their belief that they can change. Reflective listening. Check in rather than assume you know what is meant. So again, it may seem redundant, but it also opens up some opportunities for the clients to clarify what that struggle may be or what they're thinking and feeling. And it helps them process, what is my struggle? And as they're doing so, they could see why they could be motivated to change. Summary statements are really good. So at the end of a session, when you've seen them go through a bunch of different waves and different aspects of that ambivalence, you could just summarize what the key points are. Again, that helps them reflect on what's been explored and solidifies their understanding of what they've learned through that process. I'm not going to read all of these, but they'll be included in the slide deck that you get. But open-ended questions just mean that gives the opportunity for the client to elaborate. So what brought you here today? What happens when you miss your medications? Tell me more about when this first began. And just simple things like, what was that like for you? So a lot of these could be asked at the end of a reflection. You could reflect the client's experience and then say something like, what was that like for you? Affirmations. Here's just some examples. Again, I won't go through all of them, but these are really important to integrate. You showed a lot of determination by doing that. Your commitment really shows by how regularly you're coming to see me. It's clear you're really trying. With all those obstacles you have right now, it's impressive that you're being able to maintain your progress. In reflective listening, you're really taking what the client is bringing. So there's no right or wrong way to do this, but you could start statements like, it sounds like, or what I hear you saying. And in the double-barreled reflections, you could say, so on the one hand, it sounds like this, and yet on the other hand, you're also struggling with this. It just prompts the client to elaborate a little bit more about what they're feeling. And it also solidifies the connection that you have with the client because they feel like you really understand what they're going through. And it builds that compassion element. They feel like you have compassion for them and that alliance that you have in collaboratively trying to change. Summary statements are about drawing out the most pertinent points, any arguments both for and against change that the patient has brought forward. Clarify with the patient, is that correct? Have I missed anything? And ask the patient, so what do you think you'll do about that? So that kind of gives them a good idea of the journey they've been on throughout the consultation and what they're going to do moving forward. Keeps it a little bit more action-oriented. So I'm just going to play a short video, bear with me, and I might ask you to just try to pay attention to the ways the therapist is using these different skills. So keep an eye out for any reflections, any summary statements, any open-ended questions. So I'll just start playing it and hand it over.
Robbie, it's Kath. I'm not sure if you want, I think it's because you've got your headphones in.
What happens this time?
Awesome. Would you mind starting again? Thanks.
Empathizes with her situation and attempts to work with the parent to find a solution that fits her needs.
So I wrote a prescription for antibiotics for Aiden. Okay. I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently, and I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job, and so it's just, that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes, yeah. Some people have a glass of wine, I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him, and on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right, yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me, and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that. So
the risks were so scary then that you're able to stop.
Yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people. And like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
you're doing the best you can do.
Yes. Yeah.
Okay. But it sounds to me too, like part of you really does want to quit.
Yeah, I know that I need to. And I keep, every new year I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list. It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Like, I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past, and right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you. And sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure. It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
Great, sorry about the delay. So I'll just go into a little bit about what you just witnessed. So there were a lot of open-ended questions. You might have noticed the doctor used phrases like, can you tell me more about that? Right after expressing some concern and saying that I noticed that you were a smoker. Even asking open-ended questions about times where she was successful. How were you successful when you quit before? A lot of reflection statements. That was pretty, that was one of the main things that the doctor used. So right now it seems hard to manage or even try. So it's not necessarily judging, it's just pointing those things out. These are some of the ways that you can use the different strategies within the stages of change. So you're really in the beginning trying to establish rapport, raising concern, but also just bringing that to their attention. You want to normalize the ambivalence because in contemplation, they're really struggling with both sides of why they would change or why they wouldn't. You want to clarify their goals and strategies when they're in preparation because they're on the precipice of going into action. And when they go into action, you want to reinforce just how important that is, the action is to making that change. And then in maintenance, again, trying to do relapse prevention, affirm any effort that they've put in. And with lapse, you want to explore the meaning so you can learn about it or learn from the experience. Different types of change talk. It's really important to try to pay attention to when the client is using change talk and highlight that with a reflection. So when the client says things like, I would like to, I wish, I really want to, try to reflect that back, because the more we engage in that kind of talk, the more they're going to move in the direction of change. They may have reflections on their ability to change. I can cut down to 2 glasses a night. They may have reasons. I know my health would improve if I stopped. They may show that they need to change. I should do this for my children, or that they are committed to. So certain things you can do are trying to elicit the change talk through exploring what the good and bad things are, because you want to align with the client to explore what's keeping the behavior in place, but also why they might not want to be doing this anymore. Doing an evaluation of values, a lot of times if you talk about what's really important to the client, and then you reflect on how their behavior is either aligned or misaligned with those values, that really touches upon their intrinsic motivation to change that behavior. Or even an exercise like writing a letter to yourself, envisioning in 5 years in the future, if you made that change, what did you change and how did you get there? A really good tool, and you saw it in the video, is using these change rulers. So you can say on a scale of 1 to 10, how important is it for you to make that change? They may give you a low number, like 3 or 4 or something like that. But at least they didn't pick 0 or they didn't pick 1. So maybe in order to get them into the frame of mind of elaborating with change talk, ask if they say 4, why didn't they pick 1? Because now they're not justifying, if you say, well, why didn't you pick 10? They're talking about all the ways that this behavior is ingrained and why they don't want to change. Just flip the script and ask them, why not a 1? Now they're talking about, well, I'm a 4 because I actually do have some resources. I struggle, but I do have this in place. It just highlights what they have control over. There's a readiness ruler. So out of 1 to 10, how ready are you to make this change? This is maybe when they're in preparation and you want to move them over into action. How confident are you on a scale of 1 to 10? You can also play around with this. So if they're a 4 and that you ask them, why aren't you a 1? And they've explored a lot of those, maybe talk about what would have to happen to bring you to a 9. And again, use your discretion in when you time that or if they're ready. And then commitment. If willing to make a change on a scale of 1 to 10, how committed are you to that change? So this may be when they're further along the process, but it's just solidifying the commitment that they have toward making those changes. That being said, if you do get a client that you've moved from the stages of pre-contemplation, contemplation, preparation into action, you may need to come up with some resources. So depending, not all of us are in the North Sydney area, a lot of us are, but there's some, Sydney Metro and regional New South Wales resources. The Drug and Alcohol Specialist Service is a great one, and I've given you the numbers for those. Alcohol Drug Information Service, it's a 24/7 hotline. There's separate numbers for those depending on where you are. I work on the mental health triage desk as the clinical lead at the Sydney North PHN. We do a lot of referrals to services. Odyssey House and SDEC are the main alcohol and drug services that we offer, that we commission. And Odyssey House does individual and group counseling for 18 plus clients that are struggling with substance use, and SDEC are for youth. They also offer individual and group treatment. I'll just do a quick plug for Health Pathways. Health Pathways is an online tool that you can use to find where you need to direct a client if they need further treatment. It can assist with condition management, service navigation, referral to specialists, access to reference materials, and different educational resources. In the interest of time, I'll just show you quick slides of where you can find it. So the website is actually here. You can click in when you get the PDF version. It'll take you into a sign-in sheet. You can sign in using these credentials. And then if you have, someone specifically looking for alcohol and drug counseling, you might direct them to those resources. If you'd like, when you log in, you can install the desktop icon. You could start using it in your practice. So I might just turn it over to our moderators to lead a little bit of Q&A on what I've just presented.
Thanks so much, Robbie. That was really fantastic, and I know I've certainly learned a lot. And we would like it if anybody has any comments or questions about what you've heard, if you please send them through. We do have some time to talk through some of the issues and some questions that you might have. So we do have a few questions that have already been coming in, so I will hand over to Catherine, who's been managing the comments and questions that have come through.
Thank you, Chris, and thanks, Robbie. That was brilliant. I guess I thought I'd start with a comment about, how although it's a presentation on drug and alcohol, how you had very early on the range of health conditions that motivational interviewing has been shown to help with. But I think it also kind of demonstrated that this idea of motivational interviewing and our own immunity to change is something that crosses all aspects of our lives in one way or another, that it's common to all of us. And also, I just want to pick up something early on. We were talking about sort of in your exercise, the matching between the client's statements and then the what stage of change they might be at.
Yeah.
If you wanted to comment, I saw there were some answers coming through that were maybe 1 or 2 stages of change away from the direct match. I'm just wondering, based on our conversation before, if you wanted to say anything about where people sit.
Yeah, sometimes it's really difficult to evaluate where a client is, and I think that's why we try to elicit as much information from them as possible by doing reflection statements and getting them to offer up as much of their experience as they can. Because kind of those isolated quotes, it's really difficult without context to figure out, okay, is that person preparation, or does that technically mean that's an action? So really trying to get as much from the client as possible, because depending on your understanding of the client, that's going to guide your assessment of where they are in those stages of change, and that will guide what type of approach you take with them. And maybe you do a little bit more double-barreled reflections while they're in contemplation, but maybe you do a lot more affirming when they're in action, because that's what they need in order to feel that self-efficacy.
Yeah. Great, thank you. And just moving on to another question we have, that is, how can we balance building and maintaining rapport with the patient who gives nothing when we ask open-ended questions like, can you tell me more about that? No, I just don't want to do blah.
Yeah, so that's one of the beauties of this type of modality. A lot of people struggle in early stages with the pre-contemplative, but sometimes it's just about pointing out what the client's giving back to you. So if they're not giving you much, I mean, one of the tools you can use is a reflection. Right now, it doesn't seem very easy to talk about this, or, it's really difficult for you to have a conversation with me about this right now. And it may not necessarily make them springboard into spilling their guts, but it is going to at least make them feel like, yeah, that's how I'm feeling. They're not going to argue against it. You're pointing out the obvious. Even if they are a resistant client, it is rapport building, because they can see that you're meeting them where they are and that you understand. It may take, and this is why, as a psychologist, I usually get to see people more regularly so I can work on these things little by little. But you may notice slight changes over multiple sessions if you just kind of break through the armor with little statements like that to remain aligned with the client and to express to them that, like, I'm trying to meet you where you are, and I think I understand where you're coming from.
Great. And do you have any suggestions for the best ways for people to negotiate the issue of not having enough time?
That one's always really difficult, I think, for GPs in particular. With that, there's always, I think you saw in the video, if you can at least get them to explore some of these issues and maybe continue the conversation in another session, that would be great. Again, if not having enough time also means I don't have enough time to make another appointment with that client, then it is very difficult. It could just be getting people in the process of exploring that ambivalence and expressing what their reasons for change and reasons not for changing, but then giving them tangible materials like pamphlets or websites or any resources that you have. And even if you haven't gotten them into action or even preparation, just give them the materials. And if they are on that seesaw and struggling, they might even just see that, even if they don't meet with you, and say, you know what, in their vulnerable state, I might do something about this now. Because you've already started that process. You've had a conversation that's gotten them into that process of thinking about what are my reasons for changing. And sometimes just having a pamphlet or a book or a website or something to explore when you're feeling in that state of I could change can make a huge difference. You might not see it as the GP if you didn't, you know, you spent all the time you have with them, but a little resource while they struggle with that themselves can go a long way.
Yeah, we often get that sort of in the context of our clinical trials as well. I guess we have the luxury sometimes of being able to follow people up further in time. And often when we ask them, despite the fact that they may have quite complex treatments that they've been provided with, or even if they've dropped out, if we ask them what was important to them, they'll often come back to that motivational interviewing or the psychoeducation that they've been provided as some sort of stepping stone for something further down the track even. Yeah,
definitely.
Also, I was wondering whether or not, like in our research literature, I guess, there's not a lot of evidence to suggest that someone's stage of change when you initially see them is predictive at all of what their outcome is going to be. Has that been your clinical experience?
Yeah, that has. It's really difficult because I find even if people are maybe in preparation but stuck there and not necessarily taking that little extra bit, yeah, I mean, then you might even reclass them down into contemplative, but it's really difficult because you might see that person in preparation and be like, great, this is going to be easy. You just need to go this little bit further and I can get you there. And they may be the most stuck. But then if you get someone that's adamant that they're not going to change, but you all of a sudden explore their values and they're opening up about all of the reasons why they're defensive and why this behavior is so ingrained, how it's so misaligned with their values, they might change drastically. They could look like a completely different person. And you, judging by your first impression of them that first session, may never have expected it to come from that person. So yeah, I have been very surprised, usually pleasantly, thank God. But yeah, you don't get discouraged if there's people that you think, oh, they're not even close to changing, because sometimes they can really shock you and make dramatic changes.
Wonderful. Chris, I know that we have to wrap up, but I might just try and squeeze in 2 quick questions, if that's all right.
Yeah.
One from one of the participants has also said that they work in an Aboriginal community-controlled health centre as a RN and care coordinator, completing care plans, and it can be very hard for this group of people to be able to access services. Do you have any thoughts on?
Oh, I agree. It's one of those problems that I think we face. I mean, regionally, but also even in the metro Sydney area. And it's hard for that particular group to develop a level of trust with healthcare providers, especially Western medicine or Australian providers, because they don't really speak the same language or they don't think the same language. I think it's really important to find people in the community that understand it. Maybe they have a lived experience and they can support one another. It really is about trying to figure out what type of supports are available to the client. But yeah, you know what? I don't have a solution to that one, an easy one at least. I just know it's something we have to continue working toward. There are certain, I don't know if I should have probably put it in here, but there is a Aboriginal specific stages of change model that changes the language around it from less clinical or from very clinical to non-clinical. And it does help therapists who maybe have been trained in this modality to think about the language that they're using and how it impacts the client. So maybe they'll be able to have more of an influence because they're speaking the same language and feeling more connected.
Great, thank you. We do actually have a few more questions that have come in, but unfortunately I know that Chris will have to wrap up. So if it's all right with you, Robbie, if we can answer those for people later, and do you mind if people also send you emails with questions?
Yes.
Well?
Yeah, I'm available over email and I'm happy to answer any other questions.
Wonderful, thank you. I'll just hand back to Chris then to wrap up.
Great.
Thank you. So as I said a little bit earlier, we'll be making a video recording and handouts of these slides available tomorrow at the link that Robbie will put on screen now. And if you just look for the heading workforce training, you'll be able to download those. And you can claim CPD points for this activity by completing the assessment through the link on screen. And these will be available until the 28th of November. And finally, the next webinar in this series will be held on Wednesday, the 10th of July at 7:30 p.m. And that'll be on substance use in young people. And you can click on the link on this slide. Robbie, can you just advance the slides, please?
Yes.
Thank you. And thank you for joining us tonight. And thank you so much, Robbie. And I hope you all enjoy the rest of your evenings.
Thank you.
Thank you.